Oh, just like I told you, the topic this afternoon is abnormal labor. And what do we understand by the term abnormal labor? Definitely, from even the English word, anything that is abnormal it means that it is not normal. It is not the expectation. It is not what we are expected. And this abnormal labor is also termed dystocia. And the word dystocia is from a Greek word, which means the dis, that is the prefix dis, it means difficult. And tokos, that is tokos, it means birth. So in essence, abnormal labor, that is dystocia, it can be regarded as difficult labor. And you know, when the labor is difficult, it shows that it's not normal, it's not expected. I am sure in your previous sessions on maternal and child health nursing, you have been taught the normal labor. And you know what normal labor is. So normal labor, it starts as exploration of pregnancy, and you know, it progresses until the fetus and the placenta has been delivered. But anything short of that is abnormal. So the term abnormal labor can also be used interchangeably as a dystocia in the course of this discussion. So when I mention dystocia, or when I mention abnormal labor, know that we are still discussing the same concept. So what is the incidence of this abnormal labor we are discussing? So approximately 8% of all deliveries result in dystocia. And among all the 8%, uterine dystocia is the most common cause of abnormal labor. Don't worry, as we continue, you know different types of dystocia, that is different type of abnormal labor we can encounter as midwives. So uterine dystocia is the most common cause of abnormal labor. Then malpresentation are the second most common cause, and pelvic disproportion is the least common cause. I hope you are getting those concepts. Remember, your exams will come as CBT, and you are expected to master all this important information so that when you come across them during your exams, you'll be able to know, apart from it being useful for you in the course of your practice as a midwife. So now let's go as we discuss the causes of dystocia, that is abnormal labor. There are main factors causing abnormal labor or dystocia, main factors. And one of the factors is uterine dystocia, then we have pelvic dystocia, and we have fetal dystocia. So just like the name implies, you know, anything affecting the uterus causing abnormal labor, you know, that is a uterine dystocia. And anything affecting in the pelvis, remember your pelvic bone, and you know, it's an important bone in midwifery because the fetus has to pass through it to be delivered in a normal labor. Then we have fetal dystocia. So those factors affecting the fetus that may also result in abnormal labor. So these are the factors, the causes of abnormal labor. So as we go on in the course of this discussion, we'll pick each one of them and discuss them in details. But as far as the discussion of this afternoon is concerned, we'll be limited to uterine dystocia. So in our subsequent discussion, we'll be discussing fetal and a pelvic dystocia. So let us proceed as we discuss uterine dystocia. Just like the name implies, uterine, you know, anything affecting the uterus, causing the labor not to progress normally, yeah? So we call it uterine dystocia. So by the way of definition, uterine dystocia refers to a condition where difficult labor occur due to weak or excessive uterine action. So that difficult labor, that dystocia occur due to weak or excessive uterine action. You know, remember I said that anything that is out of normal, either it is hypo or either it is hyper, it is still dystocia. It is still difficult, because if the expected is below, I mean, what we are expecting, if it falls short, that is a weak. And when we have, like, let me just use this one as an example, excessive uterine action, it may also pose difficulty in that labor. So when we are talking about dystocia, don't just narrow your thinking to probably it is due to a low cause or something that is above normal. So it can either be above normal or below normal. I hope you are getting me. Now, there are some of the causes that appear to increase the risk of developing uterine dystocia. So we have some causes. Remember that anything that affects the uterus, either due to weak or excessive uterine action, is termed uterine dystocia. So what are those factors? What are those things that may increase a pregnant woman having uterine dystocia? So one of it is overweight, as you can see on your screen. So when a woman is obese, there is every tendency that the labor may result in a dystocia. And I'm sure somebody will be thinking, how is overweight, how is obese related to difficult labor? Remember that anything that is not normal can pose a problem to an individual, not even about labor alone. And when a pregnant woman is overweight, there is every possibility that that individual, that woman, have what is called hyperlipidemia. I'm sure you know what hyperlipidemia means. That is, there is an increase in the fats in that body, in that person's bloodstream. And when there is a hyperlipidemia, there is every tendency that the individual will also have what we call an increase in the level of leptin. And that leptin is an hormone, and is the hormone that maintains the normal BMI of an individual, especially in a long-term issue. So when there is hyperlipidemia, there is every tendency that leptin will also increase in the bloodstream. And when that one occurs, when there's hyperlipidemia and an increase in level of leptin in the bloodstream, so it affects the calcium signaling in the myometrium. Remember that the muscular part of the uterus is myometrium, and that is what actually comes into action during labor, because it is the contraction and retraction of that the muscular part of the uterus, that is myometrium, that actually brings about cervical dilatation and effacement of the cervix, and eventually the delivery of the fetus. But due to hyperlipidemia and increase in leptin level, so it affects the calcium signaling, which eventually affects the contraction and relaxation of the uterine myometrium, then resulting in a difficult labor. Then it has also been shown that people who have short stature can also have cervical dystocia. I'm sure you still remember your NSC 306, I think, or NSC 409, where we discuss different types of pelvic bone, and the people with a short stature may have normal pelvic bone, but the diameters are short, so it can also affect the uterine action. Then people who have masculine characteristics tend to have masculine pelvis, that is the android pelvis, and all these ones also can affect the uterine action, causing dystocia. So there are also other causes of uterine dystocia. Some of them are congenital abnormal uterus. Remember, there are different types of uterus. We have biconal uterus. We have different types of congenital abnormal uterus. And, when those abnormal uterus are present and the woman is able to become pregnant, there is every tendency that the labor will result in dystocia. I'm sure if I unmute you now, if I ask you to tell me the different types of abnormal uterus, you'll be able to mention some. We have a unicornuate uterus, we have biconal uterus. I'm sure you know what those ones means. And if you don't know them, you can go back and know more about congenital abnormal uterus. So these are also factors that may result in uterine dystocia. So another important factor is that when there's an over-distended uterus due to possibly multiple pregnancy or polyhydramnios, it can also result in uterine dystocia. I'm sure you know how multiple pregnancy and polyhydramnios we tend to affect the normal labor progress, which may eventually result to abnormal uterine action. So if you don't know it, you can do well to go and read more about it. Still talking about uterine dystocia, there are other factors too that can still cause this uterine dystocia, and one of those factors is lack of reflex stimulation of myometrium related to malpresentation. When there's malpresentation, like posterior position, brow presentation, face presentation, bridge presentation, or transverse line, then there is a disruption to the contraction of the myometrium of the uterus, resulting in a difficult labor. Also, fetopelvic disproportion. I call it fetopelvic, what we normally call CPD, that is cephalopelvic disproportion. But we call it fetopelvic disproportion here because when you are talking about cephalopelvic disproportion, it shows that the presenting part is the head, the cephalic, but there are instances where the presenting part will not be the head. So it is better to put it as fetopelvic disproportion. So in cases of fetopelvic disproportion, then there is bound to be uterine dystocia. So then uterine activity usually slow if the pelvis is too small for the fetus to descend. Then another thing is overstimulation of the uterus with oxytocic drug. All these factors, either singly or combined, may affect normal uterine action, resulting in uterine dystocia. I hope you are following me. If you are following me, can you just drop a message in the chat box to know that you are following me? Just drop a message in the chat box to be sure you are following me. I'm still waiting for your messages if you are indeed following me. Hello? All right. Okay, thank you. I can see that you are following. Now let's proceed further in our discussion. Now, still on uterine dystocia, extreme maternal exhaustion causing the adrenal medulla to secrete catecholamine that interferes with uterine contractility. This is also a factor that may cause uterine dystocia. So, remember your adrenal medulla, it secretes some hormones that interfere with a uterine contraction. So, and when this one happens, when there is extreme maternal exhaustion, and if I may ask, what are those factors that may cause extreme maternal exhaustion? When there is maternal distress, the woman can actually be exhausted. And when that one happens, the adrenal medulla is stimulated to produce catecholamines, and these catecholamines, these hormones, they interfere with the uterine contractility, thereby resulting in uterine dystocia. Also, other factors are dehydration, electrolyte imbalance, the administration of analgesics too early in labor. All these together can cause uterine dystocia. Now, having discussed the factors that can cause uterine dystocia, remember we are talking about abnormal labor, so don't let us lose that focus. The focus this afternoon is abnormal labor. And for those of us who are just joining, we have said it that there are 3 factors that may lead to abnormal labor. And one of those factors are the uterine factors, that is uterine dystocia. And we have discussed uterine dystocia in extensively. Now, let us see what can cause fetal dystocia. This one has to do with the fetus in utero. And what are those things? Difficult labor may be due to the size of the baby, the fetus, the shape, and the presentation of the fetus. So when we talk about the size, the shape, and presentation of the fetus, it's usually related to abnormal fetal presentation or position. We have also discussed that one when we were considering the uterine dystocia. The face presentation, the brow presentation, and the transverse line of the baby. These are the fetal factors. The uterine action may be the uterine contraction may be very okay. The contraction and realization of the uterus may be very okay, but when there is a abnormal presentation, abnormal position, there may be fetal dystocia. Other factors that may cause fetal dystocias are fetal anomalies such as hydrocephalus, abnormal enlargement due to tumor or conjoined twins or even locked twins. Then fetal macrosomia, usually greater than 4,000 grams. Like 4,000 grams is a 4 kg when you do your conversion. So most of the time, fetal macrosomia may cause difficulty in labor. And this one will actually make me to remember in one of those days when I was in the labor room. I was working in a private hospital then as a midwife. When a pregnant woman comes in labor, you only need to alert the doctor to let, I'm sure in private hospitals in Nigeria, you understand what I'm saying, that you can be all in all. And that particular woman came in labor. So when I examined the woman, the cervix was, the uterine contraction was very okay. The cervix is dilating. The effacement is okay. And I was actually anticipating normal labor. Not until I got to the second stage of labor, the cervix is fully dilated. The head has cramped. I'm sure you remember your mechanism of labor, putting all those mechanism of labor in play now. So after the delivery of the head, so waiting for internal rotation so that the shoulder can be delivered, and our normal mechanism of labor, I just discovered that there is shoulder dystocia. I was unable to deliver the shoulders because they are very broad. The long and short of this story is that eventually, while we were preparing for an emergency cesarean section, the woman eventually pushed through and the baby, the fetus was delivered. But upon weighing that baby, the baby weighed up to 4.2 kilograms. And we are very funny in Nigeria, not knowing that this woman, where she initially booked her pregnancy, they had already told her that the baby is too large and they may plan an elective CS. But because she doesn't want a cesarean section, so she left the hospital and came to the facility where I was working then. And I was on night duty. And eventually we had that incidence of a shoulder dystocia. You know, when shoulder dystocia is also one of those factors, one of those fetal factors that can cause fetal dystocia. So it happens, and that is why, as midwives, we must be skillful and we must be alert to any eventuality when a woman is in labor, because labor can progress very well even at the point of second stage when you begin to have difficulty. Even it can be at the point of third stage when the placenta is delivered and the woman has hemorrhage and all that. So we should be alert and we should assess our pregnant women very well so as to be on the lookout for any eventuality that can occur in the course of that pregnancy. So let us continue now, still on factors that can cause abnormal labor, that is dystocia. So the third factor is a pelvic dystocia. So pelvic dystocia refers to difficult labor that can occur as a result of anything that has to do with the pelvic bone. So, and those factors may be due to small pelvic inlets, mid-pelvis, or pelvic outlet as a sort of hereditary previous pelvic fracture or disease. I'm sure you still remember your pelvic bone when you are asked to describe the pelvic bone, especially the gynecoid pelvis that is the most suitable for labor. Remember, you have your pelvic brim, you have your pelvic inlet, you have your mid-pelvis, and you have your pelvic outlet. So anything affecting all this landmark on the pelvis as a result of hereditary, previous pelvic fracture or disease, all these factors can result in pelvic dystocia, which may eventually cause abnormal labor. I hope you are following. If you are still with me, let me see your yes in the chat section. Let me see your yes in the chat section. I have seen about 4 participants, students raising up their hands. If you don't have any question for me, you can do well to bring those hands down. And if you have any question, you can wait till the end of this discussion so that we can discuss your questions together. I want you to know that any question we have, because midwifery is actually practical, any question you have, we will discuss them together. So if you don't have any question, you can do well to bring down your raised hands so that we can continue this class. Thank you. Now, let us go to the pathophysiology. And talking about the pathophysiology, we want to discuss 2 things as they affect the labor that eventually make that labor to be abnormal. We want to talk about hypotonic uterine activity. We want to talk about hypertonic uterine activity. We want to talk about both hypotonic and hypertonic. Remember, when we started this discussion, I mentioned that for abnormal labor to occur, the factors may either be those ones that make uterine contraction to be inefficient, and those factors that make the uterine contraction to be hyper. So, and that is why discussing the pathophysiology now, we will consider them in two phases, because abnormal uterine action can either be hypotonic or hypertonic, because going by all those factors, the uterine factors, uterine dystocia, fetal dystocia, and pelvic dystocia, the ultimate resultant effect on labor is that there is a kind of an incoordination in the uterine activity. So having said this, let us briefly see what hypotonic uterine activity is. So hypotonic uterine activities occur when the rise in uterine pressure during a contraction is insufficient to promote cervical effacement and dilatation. You know, that contraction is like a kind of pressure being mounted on the myometrium of the uterus. So that pressure actually promotes, under normal condition, should actually promote both cervical dilatation and cervical effacement. I am sure you know what cervical dilatation and cervical effacement means. If you don't know it, you have to go back to your previous lectures in MCH, especially during the course of your normal pregnancy, normal labor and purperium, to refresh your memory about cervical effacement and dilatation. But you remember that without cervical effacement and dilatation, normal labor cannot progress. So talking about hypotonic uterine activity, so that pressure, if it is less than 25 millimeter of mercury, cervical dilatation and effacement cannot occur. So that is hypouterine activity. So what it means is that the force provided by the voluntary contraction of the abdominal musculature facilitated by the urge to push may be insufficient to facilitate fetal descent and delivery. Remember that when there is good uterine contraction, the upper uterine segment, as it is becoming shortened, the fetus will be descending. So as the upper uterine segments, due to contraction and relaxation of the uterine muscles, so the upper uterine segments become shortened and the lower uterine segment becomes dilated and thin out. So that is just the mechanism behind the normal labor, in which the cervix is fully dilated and the baby is born. So any force, anything that may hinder this normal process, that will not make that fetus to descend, then it will cause an abnormality in labor. So, and one of those factors is that the pressure required to generate that contraction may be less. So if it is less than 25 millimeter of mercury, we call it hypotonic uterine activity. Is that okay? So let us continue. So, you know, when we have hypotonic uterine activity, just bear it in mind that there is every tendency we have hypertonic uterine activity or uterine contraction. And you know, when we are talking about this hypertonic uterine contraction, it can also be incoordinate uterine contraction. I hope you are following me. So talking about hypertonic or incoordinate uterine contraction, what happened here is that there are contraction. So the contractions are frequent and they are painful, but they are ineffective in promoting effacement and dilatation. Remember that if we need to have a normal labor, there should be, when there is uterine contraction, it should be accompanied by cervical dilatation and effacement. So any form of any form of contraction, either hypotonic or hypertonic, that will not result in cervical dilatation and effacement may not make a labor to proceed normally. So now, in the case of hypertonic or incoordinate uterine contraction, we have frequent contractions. In fact, they are very painful and they are very strong, but they are not being accompanied by effacement and dilatation. So they can be very ineffective because the uterine pacemaker that arise in other area of the uterus, let me quickly mention this. When we talk about pacemaker, I'm sure what our thoughts will go, where our thoughts will go is the SA node of the heart, that is sinoatrial node of the heart. But in the uterus, we also have uterine pacemaker, and they are located at the tuber ostia. So around the tube are those where the pacemakers of the uterus, where they are located. So, and they actually help to do what? To aid the uterine contraction. So they help, to aid the uterine contraction. Now, just like I said earlier, so this ineffective contraction, remember that for hypertonic, there is contraction. They are painful, they are strong, but they are not effective. They are not effective because the pacemakers that should normally be around the tube, the uterine tube, that should actually help those contractions to spread down the uterus are not located where they should be. Instead, this causes the uterus to contract sporadically but ineffectively, and the presenting part is not forced down. Do you understand what I'm saying? Remember I said that normal uterine contraction should actually proceed from the upper uterine segment. So when it proceeds from the upper uterine segment, it actually helps to shorten that upper uterine segment. And when the upper uterine segment is shortened, so the fetal descend into the pelvic. So, but for hypotonic or incoordinate uterine contraction, the contraction are not effective because the force of the contraction are not actually making the fetus to descend, and this can actually result in prolonged labor. So, and remember that any labor that has gone beyond 12 hours, it is termed prolonged, regardless of either there are effective contraction or ineffective contraction. So I hope you have gotten that. Now, we need to talk about two types of ring that we should be on the lookout for when we are discussing labor. In a normal labor, you may not encounter these types of ring, but in abnormal labor, there is tendency you have either of them. And one of them is the constriction ring. One of them is the constriction ring. And the constriction ring occurs due to hypertonic colicky uterine action. Now, we want to, if you are following me and you are able to actually merge everything I've been saying together, you remember that previously I had mentioned that in a hypertonic uterine contraction, which can also be called incoordinate uterine action, there is very strong, painful uterine contraction. but they are not effective enough to produce fetal descent, to produce cervical dilatation and effacement. So, and when this one occur, it can cause constriction ring. It can cause constriction ring. And remember, I told you when that one continue to occur, the labor can be prolonged. So in prolonged labor, there's every tendency you have constriction ring if effective intervention is not instituted. I hope you are with me. I hope you are with me. If you are with me, let me see your yes again in the chat section. So many people are leaving. So many people are leaving the chat. Okay, thank you, thank you, thank you. I can see so many people still here with me. So, and I'm sure you are with me and you are also following me. So constriction ring occurs due to hypertonic colicky uterine action. And you know that hypertonic colicky uterine action are the features of hypertonic uterine action, which is also called incoordinate uterine action. So this constriction ring is a localized, when there's a localized spasm of the ring of muscle fiber, which usually occur at the junction of the upper and lower uterine segments. So the constriction ring is located at the junction between the upper and lower uterine segments. Then it is rare and may arise during any stage of labor, though it is common in the third stage. So just bear that one in mind. It may arise, it is rare, but it may arise during any stage of labor, but very common in the third stage of labor. So we have discussed hypertonic stroke incoordinate uterine action. So let's go further to discuss obstructed labor. When there is abnormal uterine action and as a skilled midwife, if you don't take cognizance of it, if you don't recognize it early, it can lead to prolonged labor, just like we have mentioned, and also it can also lead to obstructed labor. So this will lead us to discussing briefly what we mean by obstructed labor. So what is obstructed labor? It occurs when there is no progress of presenting part despite uterine action. So there is no progress of the presenting part. Now, the presenting part, normal presenting part should be the cephalic. So when there is no progress, then you can be envisaging obstructive labor. So the obstruction usually occur at the pelvic brim, but may occur at any part of the pelvic, that is the pelvic outlet, like a deep transverse arrest in the android pelvis, but usually it occurs at the pelvic brim. So what are the causes? Fetopelvic disproportion, deep transverse arrest, fetal abnormalities, locked twins, malpresentation, pelvic tumor. I'm sure you can relate all these causes to why there can be obstruction. That is where there will be no progress of the presenting parts despite strong uterine action. If, for example, in the case of locked twins, when they are locked together, despite that there is good uterine action, you may not be able, because there will be a kind of obstruction. There will be a kind of obstruction in the presenting part. Also, malpresentation. Remember that if there is a transverse lie, it can cause, if it is not recognized early, and the attending midwife is still anticipating normal labor, especially with traditional birth attendants and unskilled uh, personnel parading themselves as midwife. So if these causes are not put are not being looked into critically and they allow that labor to progress despite the obstruction, then it can be very fatal. Now, still talking about obstructed labor. So, what are the things you see when we talk about obstructed labor? The uterus become molded around the fetus and does not relax properly between contraction. Do you understand that? Instead of the fetus, to be um, shortening, and the fit and instead of the uterus, the length to be shortening, the shortening of that length of the uterus will actually be propelling the fetus into the pelvic area where the fetus will escape. The fetus will be molding around the fetus, so it makes it really difficult, and it actually causes that obstruction. So when there is this molding of the uterus around the fetus, so this becomes stronger and more frequent until the uterus is in a state of virtually continuous tonic contraction. So remember, in obstructed labor, there is tonic contraction. And what would be the clear feature of obstructed labor? Please note it. If you can view my screen now, you will see that I indicate some words in red. So those are the things you should actually take note. So when there's obstructed labor and there's strong uterine contraction, so the lower segments becomes thinner and longer. I know during normal labor, what the lower segment should do is to become short and phased and effaced, but in obstructed labor, the lower segments become thinner and longer, and the upper segment becomes shorter and thicker. So these are the features of obstructed labor. So when the lower segment is thinner and longer and the upper segment is shorter and thicker, there is another ring called the traction ring, and it is otherwise known as Bandus ring. So it will be visible abdominally. That Bandus ring will be visible abdominally as an oblique ring above the symphysis pubis. I hope you have taken note of that. So the Bandus ring mark the junction between the upper and the balloon out lower segment. Now, still on obstructed labor, can you see that diagram on your screen? Look at the upper bundle of the lower uterine segment and the over distended uterine segment. So it actually looks like the bladder is full. When there is a Bandus ring, it looks like the bladder is full. But when you catheterize that bladder, you just get little urine, because it is not really that the bladder is full. Or even when the bladder is full, that obstruction may actually hinder you from really reaching to get more urine. Then, so these are the features when there is a Bandus ring. So it appears as if the bladder is full, except that the ridge is an oblique angle across the abdomen. So it's like and when you catheterize the pregnant woman, you get little urine. Then uterine exhaustion may occur in a primigravida. So the woman will be exhausted. Then the vagina feels hot and dry. Take note of that. The vagina feels hot and dry. Then the presenting part is high and feels wedged and immovable. I think you know why that one will happen. The upper uterine segment is not actually being shortened, so the placental part is still high in the uterus, and it feels well and immovable. Do you know the uterus is moving around the placental part? So that is why it feels wedged and immovable. And there is excessive molding of the fetal skull, and a large caput succedaneum is present. So upon your examination, your vaginal examination and abdominal examination, if you could have these features, you know that there is obstructed labor. And as a skilled midwife, you don't allow these ones to present before you take necessary action to save the life of that woman and that of the fetus in utero. So on this note, this afternoon, we have come to the end of today's class. So before this week runs out or early next week, we'll have another class to continue our discussion or to conclude our discussion on abnormal labor. And if time permits us, before you come for your face-to-face facilitation, we can also discuss abnormal puerperium. Because remember, I told you during the course of the introduction to this course that when we talk about abnormal midwifery, we talk about abnormal pregnancy, abnormal labor, and abnormal puerperium. We have been able to discuss abnormal pregnancy. We have started abnormal labor now, and we would continue as much as we can to go into abnormal puerperium so that you can have a complete lecture on this this course NSC402. Meanwhile, you don't have to worry. I know that on the LMS, you have your lecture notes on abnormal pregnancies. That is study sessions 1 to 6. We'll upload this for you to read on the LMS for abnormal labor, because you expect questions to come from everything we have discussed in this course of your course on NSC 402 during your exams. So before I call it a day, let me give room for any questions. Probably we have big midwives in the house who would want to add more to what we have discussed. So I will open the floor now for questions and for clarifications and for any other thing. Please, we are responsible adults. You don't have to talk when you don't have anything to say. I will unmute you now. I will unmute us, or let me do it this way. If you have any question, you can raise up your hand so that I can unmute you so that you can talk, so that we will not make the class to be very rowdy as we always do. So if you have question, raise up your hand. Let me unmute you for you to talk. Thank you. Question? All right, Blessing. Let me unmute you so that you can talk. Okay. Blessing, you can unmute yourself and talk and ask your question.
All right. Good afternoon, ma. Thank you very much for the lecture, ma.
Yeah.
Okay, ma, please, mine is not really a question. I couldn't join in early.
Okay.
My network was really bad.
Okay.
So please, can you just help to go through the slides briefly, like the beginning. I couldn't really screenshot the slides, but I'm doing
Sorry,
screenshot.
you don't have to screenshot the slide. Latest by tomorrow, I will upload this slide on the LMS for you people to have access to it. Even the recorded version of this class will also be uploaded on the LMS. Is that okay?
It's okay, ma'am, but please, if you can still help to go through the slides now.
Or you have not paid, or you don't have access to the LMS.
No, I have. I
Okay.
actually do have that now.
Don't worry. So, as I am welcoming other participants who may have questions, have you started seeing that I've began to share
Yes,
it
ma'am.
yeah. So
Yes,
I will do that while I wait other people to ask their question if there is any.
Okay, thank you so much.
All right. Any other question? Any other question? I hope Blessing is getting it as I am. I hope I'm not too fast. So I can see that we don't have any other question now. So I'll just go through my slides again before I call it a day. So we still have about 2 or 3 classes, though it can be actually compressed into two or 3 classes before we come for our face-to-face facilitation. Another important information for all of us, some people are not joining class. Fine, I understand that the participants, the capacity of our WhatsApp cannot take more than 300. But okay, I will, by tomorrow, a quiz will be uploaded for you to attempt. Please, I'm begging now. Please tell your colleagues that are not here. Please tell them to attempt the quiz before the time elapsed, because no quiz will be reopened after the due date. Please, some people will come begging, but me, I am begging now. Please, 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 please. When the quiz is uploaded for you, you will be notified. Please and please attempt your quiz. These days is part of the overall assessment. Attempt your quiz before it is due. Don't go and be telling the HOD to tell the e-tutors to ask the tutors to reopen your quiz. I may not reopen any quiz after it has elapsed. I hope I have communicated, and that is, I am speaking the mind of my other colleagues, my 2 other colleagues, Mrs. Adeniji and Mrs. Olamijulo. So I'm not talking on my own, so that I know what people can do. When they can't get me, they go to my other colleagues and ask them, we want you to reopen the quiz. None of us will reopen the quiz, but we'll give you ample opportunity to do the quiz. Is that okay? Thank you. Blessing, I hope you have gotten the slides now. I hope you have gotten the slides. So, is there any other question? Is there any other question? Nobody is raising hands up again. So I think this will be a convenient time to say Bye for now. See you during the next class. Time and date will be communicated to you. Thanks for coming. Have a nice evening. Bye-bye.